Welcome to Melina Brea Tar Pits, where history comes alive. We have saber-toothed tigers and giant ground sloths. See how majestic they are? Sort of. I mean, we have some animatronics. They're not actually alive. Genetic cloning from mosquitoes preserved in amber? That's just a myth. We're not experimenting in that big white building behind you. Pay no attention to the figurative man behind the curtain. To distract you from that ominous white building, let's talk about our clinical patient. Mr. Jones is presenting looking like he's pretty sick. Just look at those vital signs. With tachycardia, that white blood cell count, and that hypotension, I'd say he's got septic shock. Sounds like they did the right thing by intubating him and getting him to the ICU. And based on the fact that he's had pretty bad pulmonary symptoms just after having the flu, I'll bet he's got pneumonia. And yep, they've got him on IV antibiotics too. But all that isn't really what the question is asking, is it? 2 days after admission, he starts having black sticky stools. Gross. And his OG tube has started having black flecks that look like coffee grounds. And he's definitely bleeding. His hemoglobin has dropped significantly in just 12 hours. They also make a point of telling us that his blood pressure has remained low and he's still needing vasopressor support. I wonder if that has something to do with all this bleeding. Acute upper GI bleeding is a potentially life-threatening condition that requires prompt evaluation and diagnosis. Life-threatening means that it could cause death, sort of like this saber-toothed tiger here. Upper GI bleeding is typically divided into non-variceal and, variceal. Variceal bleeding is its own can of worms, so head on over to that sketch to check it out. General upper GI bleeding, on the other hand, typically presents with some combination of 3 similar symptoms: hematemesis, melena, or hematochezia. Hematemesis comes in 2 flavors. Coffee ground emesis and bright red hematemesis. Coffee ground emesis is typical of slower bleeds and appears so due to partial digestion of blood in the stomach. Assuming that Mr. Jones from our clinical case didn't have a chance to eat a bunch of coffee grounds, I think we can assume those black flecks coming out of his OG tube is this coffee ground emesis. If patients are throwing up red blood, it usually means they've either just mauled a giant sloth like the saber-toothed tiger has, or else it means that the bleed is much more brisk. In fact, lots of red blood on NG or OG suction is a pretty good indication for early endoscopy. Melena comes in one form: black, tarry stool. And the smell? Oh, you'll know it. Think of scents of rusty iron mixed with C. diff diarrhea, and you'll get close enough. Ugh, I might throw up. Who wrote this? What is with these nasty descriptions? Melena's exquisitely dark color is due to the digestion of blood as it passes through the GI tract. As such, melena is typically considered a sign of bleeding proximal to the ligament of Treitz, which is the transition point between the duodenum and jejunum. Is that always the case? No, but it's the classic definition and it will definitely come up at some point. So keep the ligament of Treitz in mind. And thinking back to our clinical case, that melena Mr. Jones is having helps us narrow down the source of the bleeding to the upper GI tract. Hematochezia, or red blood from the anus, is the switch hitter here. While most cases of hematochezia are due to lower GI bleeding, think diverticulosis, up to 10% of hematochezia can actually be due to brisk and serious upper GI bleeds. It's obviously important to differentiate the two when it comes to treatment, as performing colonoscopy is important in the workup of a lower GI bleed, but it's of little utility in the case of an upper GI bleed. Other signs and symptoms may give a clue as to how severe the bleed is. If less than 15% of the blood volume is lost, there are usually minimal symptoms and vital signs are normal. Tachycardia alone is the first sign, and it signifies more than 15% blood volume loss, and orthostatic hypotension also may begin to present at this point as well. Ew. Kid, that's not somewhere you want to go swimming. Orthostatic hypotension is a fall in systolic blood pressure greater than 20 millimeters of mercury, or a rise in heart rate greater than 20 beats per minute when changing position from lying to sitting or standing. If the patient has sustained significant hypotension or has cool, clammy skin, look out, as this could mean up to a 30 to 40% loss in blood volume and the beginnings of true hypovolemic shock. Luckily, most patients come in before it gets this bad. We have this information on hemorrhagic hypovolemic shock thanks to some research we're conducting on maulings by lions. Well, at least we used some lion DNA to splice into their genomes where they were missing some parts. You know, from the amber, which I can neither confirm nor deny we have possession of. For more information, check out our superhero sketch on hypovolemic shock. Since prompt diagnosis is crucial in upper GI bleeds, it's important to recognize any risk factors the patient may have that make upper GI bleeding more likely, such as a history of peptic ulcer disease, particularly in the duodenum, which is the most common cause of upper GI bleed, by the way. Check out our PUD construction site sketch for more info on the etiology, clinical presentation, and management of PUD. We didn't get a chance to talk with Mr. Jones before he got tubed, but if we had, might we have heard a history of ulcers? We could still chat with his wife to see. She said no. So, well, how about some less common causes? That food truck smells great. Acute erosive gastropathy may cause upper GI bleeding. Let's remember back to our Japanese street scene of our gastropathy sketch to go over some of the causes. Critical illness, trauma, or sepsis can all lead to hypotension, which can lead to decreased gastric mucosal perfusion, and that can lead to acute gastropathy or ulcer formation, also known as stress ulcers. That sounds familiar. Mr. Jones is definitely critically ill and has sepsis. Some vasopressors may also decrease splanchnic blood flow and can cause decreased perfusion, and he's been on some of those too. CNS trauma and the increased vagal activation that goes along with it may also lead to the famed Cushing's ulcer, and severe burns with resultant hypovolemia can lead to Curling's ulcers. Point is, critical illness in many forms can lead to gastropathy or ulcer formation. So you have to be on the lookout for high-risk patients who all need some sort of GI prophylaxis. Well, I don't remember our clinical case patient being on any GI prophylaxis. It actually said there weren't any other medications other than the ones listed, and none of those were a PPI or an H2 blocker. So, without GI prophylaxis in this critically ill patient, we have our first answer. Let's finish our review of acute erosive gastropathy before moving on to other causes of upper GI bleeding. NSAIDs, chemotherapeutic agents, heavy alcohol use, and cocaine are all associated with acute gastropathy, usually due to their direct toxic effect on the mucosa, except cocaine, which is due to mucosal ischemia from vasoconstriction. Another cause of GI bleeding is previous abdominal aorta surgery, especially open abdominal aortic aneurysm repair, which can lead to aortoenteric fistula formation, which, yes, is a connection from the aorta to the bowel. Rare, but possible. And it can cause massive hemorrhage. We're talking fast exsanguination unless they can get to the OR double stat. It's also important to rule out imitators of GI bleeding. Medications such as bismuth or iron supplements can cause dark stools that can be misinterpreted as GI bleeding. That's bismuth, iron, and amber found right here at the Melena Brea tar pits. It's at least 1 million years old. That's super old. What's that? Where's the amber? Did I say amber? I didn't mention any amber. You must have heard me wrong. We have no record of... Please turn your attention away from the genetic laboratory in the background where certainly no amber is being processed to genetically recreate extinct animals like the majestic saber-toothed tiger. Moving right along. Don't drink the melanotar? Don't have to tell me twice. You may have to tell that kid from earlier, though. Not really sure why he was so close to the edge in the first place. The initial management of all patients with a suspected GI bleed starts with a quick run-through of the ABCs to ensure stabilization. Patients should be made nil per os, meaning NPO, and have 2 large bore IVs placed as a precaution if the need for rapid fluid administration should arise. Usually, at least some crystalloid is started. Oh, look. This caveman was certainly ahead of his time. He even has the first example of a calculator. It's not totally clear to me how he made that before the invention of the wheel, though. I mean, come on. He's still driving that old mammoth around. In any case, let this abacus remind you that in patients with upper GI bleeding, a hemoglobin level should be checked and rechecked in a serial manner. Although with acute bleeding, hemoglobin and hematocrit may be normal. This is because patients with acute bleeds lose whole blood, plasma included. So, the concentration of hemoglobin and RBCs in the blood may not change for several hours as the body retains fluid to maintain perfusion pressures. Blood transfusion may also be needed, so better get that type and cross also. In our clinical case, Mr. Jones has a drop in hemoglobin, so the bleed must have started beforehand. And as with any bleeding patient, coagulation labs, including PT-INR, PTT, and platelets should be checked as well. Dilution of blood clotting factors as bleeding continues may make it harder